Financing incentives can be a very powerful tool to contribute to that. You will see from the speakers that perhaps it's not enough, but financing incentives is a very powerful policy lever to enable that the systems pursue the primary healthcare attributes or goals. So, and the session is going to focus and listen to multiple panelists that will provide ideas of how financing incentives are contributing to primary healthcare goals. So, we don't have lots of time, and we have a very rich panelists to learn from. So, before the flow of the session will be, we will have a keynote speaker, and then we will have 7 panelists which will have short interventions to quick points to stimulate our collective learning on how to use financing incentives for primary healthcare reforms. So, without further ado, I want to invite my friend before, which is Dr. Triin Habicht. Sorry, I never pronounced your surname well. She's lucky enough to live in my city. So she works for the WHO office in Barcelona and will frame the
primary
session.
Healthcare can be the stair.
Okay.
Over to you.
Thank you so much, Lluis and Anna. What I really try to do is to set the scene for this following panel discussion and to discuss very briefly what are the key challenges we are seeing in primary healthcare financing and what are the potential ways how to overcome these challenges. And I will rely on the health system framework. I'm sure many of you have seen this framework or have seen something similar, like it's a bit maybe differently put. I will not definitely go into all these details of this framework, but what I want you to focus on is that how different health system functions are contributing to achieving health system goals. So it's how health financing in this session helps us to achieve universal health coverage in a way that people are better protected from financial hardship and people do not face barriers that end up being in unmet health needs. And as I said, I will focus on health financing functions, how revenues are raised to finance primary health care. It's very important because I don't know who has been that wise man saying in the past, but tell me where your money is and I will tell where are your priorities, and that's very much about it. Then pooling. Pooling is how to consolidate funds because that's important if we want to redistribute and to make sure that primary healthcare financing is aligned to population needs. Then coverage policy. Who is covered? To which services is covered and to what extent is covered in a way, what is the co-payment design in the country. And then finally, a little bit about purchasing, so how primary healthcare providers are actually paid. Let me start with revenue raising. And just to give you some context from European region, if you take, for example, Switzerland, one of the richest countries in our region, and then Tajikistan, one of the poorest countries in our region. And if you compare per capita spending on health, then the difference is 150 times. 150 times. And believe me, it does have impact on what these countries can afford to pay for at the primary healthcare level as well. In this slide, you see all countries globally, and they are grouped according to income groups. And this yellow slice of the pie shows how much these countries are spending on primary health care. And what you see is lower and middle income countries spend more. But it's not enough to look only on that. If you look lower and middle income countries, you see, if you look inside this yellow slice of that pie, you see that it's mostly red color. And red color shows how much of that primary healthcare spending is paid directly from out of pocket from patients. It means that patients need to pay for these healthcare services when they are seeking care from their family doctor or they are buying medicines from the pharmacy. And we have plenty of evidence available saying that if people need to pay out of pocket, it causes financial hardship and it undermines countries' efforts to make a progress towards universal health coverage. What is important here that although poor countries have, of course, very much different possibilities, like it's what they can do, but progress is possible in every country, and countries can look their budgets and how much they spend on health from their government budgets, particularly how much they spend on primary health care. Let me come to the next, the second health financing function, which is pooling, which is how funds are consolidated. And this function is especially important for those countries where primary health care is financed from the local government's budgets. And you see here 5 districts from Tajikistan and how primary healthcare budget is currently allocated to these districts, because there is also district level financing for primary healthcare, how it is this year as a budget plan. What you can see is that there is a 3-time difference. It's one oblast, 5 districts from that one oblast, but you see 3 times difference, or 2 times difference, sorry. It's a bit more like 2 times difference, how much these districts are spending on primary health care. And believe me, it's not linked to because health needs are higher, it's because historically budget planning has been like that. And therefore, it's pooling these funds at the oblast level, at least, gives possibility to reallocate these funds more equally, more equitably, and according to population health needs. And Tajikistan is exactly planning this health financing pilot at the moment, and you see these green dots are just like how the distribution would look like if every district receives equal amount. But of course it might need further elaboration to take health needs, which might be different by these districts, also into account. Let me come to the coverage policy. And the first is a population coverage. I think we all agree that it's very important that primary healthcare, comprehensive primary healthcare, is available to everyone in the country. So it's probably not difficult to agree on that. But here you can see in this graph selected countries from the European region. And if you look right side of this graph, you see that not all countries covering under 100% of their population with their main health financing scheme. And what you also see is that mostly these countries are indicated with red color. It means that those countries have the health insurance system where the payment of contributions is actually preconditions to have access to care. Of course, in some of these countries, primary health care is available to everyone. But for example, if you take my country, Estonia, 5% of population has no insurance coverage, and they are not covered with primary healthcare services. So they need to wait until their health situation is worsening enough that they are eligible to emergency care. It doesn't make sense, right? And therefore, it's really important to make sure that everyone, really everyone, is eligible to primary healthcare services. Now, let me look into the second dimension of the coverage policy, which is cost coverage. What is here, it's a bit complicated figure, I know, but here are again selected countries from the European region. On the left side, countries with stronger financial protection, less households facing catastrophic health spending. On the right side, countries with weaker financial protection. But I want you to focus on these dark blue bars, which are much higher compared to light blue bars. These are 20% of the poorest households who face catastrophic health spending. The median, or like it's an average value, is about 20%. So 20% of poor households face catastrophic health spending. But if you look, in some countries it's 60% or even more. So, which means that 6 out of 10 poor households is facing catastrophic spending because they need to pay for healthcare. So you may ask, is it relevant for the primary healthcare? So let's look inside these blue bars. So what services actually drive that financial hardship? And Natasha showed that a bit in a different way, but the message was same. Because if you, during the first plenary session, if you look, this slide has mostly red color. And red color indicates medicines. So for the poorest households who face catastrophic spending, medicines are the key driver. And of course, there is no comprehensive primary health care if medicines are not part of the primary health care benefit package. And let me finish coverage policy with one example from Ukraine, is because if we take a population perspective, then to make coverage policy really to work, it needs to be transparent and people need to understand it. And that was one of the objectives alongside increased financing in Ukraine's primary healthcare reform. And as a result, what they managed to do is to reduce informal payments for primary healthcare services almost 3 times. And countries facing issues with informal payments know how difficult it is to achieve it. And let me now come to the final. I know that I'm running out of time. It's purchasing. I will not go into details of purchasing, but I know that you will discuss it more during the panel discussion as well. The first very important takeaway is that service package, what we promise to people, needs to be aligned with the budget available and also the level of primary healthcare payments. Because otherwise, we may promise very generous benefit package to the population, but primary healthcare providers are not able to deliver it and make it accessible. The second is, which relates to the Estonian example on that figure on the right side, is that countries tend to move more to the blended payment methods, so moving away only from capitation-based primary healthcare financing. That is exactly what has happened in Estonia during the last 20 years. 20 years ago, more than around 70% was capitation payment. If you look now, less than half is capitation. And over the time, different additional financial incentives have been added because there are service delivery objectives, and Estonia has been using financial incentives to help actually primary healthcare providers to move towards these service delivery objectives. The third takeaway from purchasing is that regular payment methods are not often enough. If we really want to see transformative change in primary healthcare, for example, if we want to move from solo practices to multidisciplinary primary healthcare teams, you might need upfront investments into infrastructure, investments into human capital, and monitoring. Because quite often we see that we really lack data in primary healthcare. One reason is that we have been using capitation payment that does not incentivize data recording. But if we don't have data in primary healthcare, it's very difficult to justify that current budget is well spent, and it's even more difficult to make a case that primary healthcare needs more funds. If you are interested in more, then after this session, we will launch the Primary Healthcare Primer. Chapter 9, if I'm correct, is about financing. If you are interested more in country case studies, then WHO Barcelona office, where I come from, has been publishing 4 country reports on Moldova, on Kyrgyzstan, on Georgia, and the most recent one from Ukraine. And let me finish with the quote from the relatively recently published Lancet Global Health Commission on primary healthcare financing, helping us to remind that designing financial incentives is not only a technical exercise, it's very much about political choice and changing financial incentives, allocating more funds to primary health care does require strong political commitment. So thank you so much.
Thank you very much, Triin. It's difficult to find someone as passionate as Triin to present the role of health financing and primary health care. Just two quick comments. One is very important. Triin has not just covered the purchasing part, which is, normally when we are focusing on the role of health financing for primary health care, we think about how to pay the providers for the policy goals. She also brought us the entitlements, how to raise them, and the management, the poolings, and the fact of cross-subsidization that needs to be pursued. And the second point is the data. It's important to go beyond averages and the generation of data for evidence. So, two key points that I take from Triin intervention. Anna?
Thank you so much, Lluis. Triin, thank you so much for this crash course in health financing. Now that we have heard about all the key elements of the financing function, I would like to invite our highly esteemed panel of experts from countries and 2 institutions to comment on all these elements and unpack them a little bit more, enriching with their own personal experience from their context. Let me please invite Klara Oskombaeva, who is first deputy chairman of the Mandatory Health Insurance Fund under the Ministry of Health of the Kyrgyz Republic. I believe Klara will be speaking in Russian, so please put your headsets on in case you cannot understand. We have with us also Manpreet, who is the regional primary healthcare financing expert for Europe and Central Asia at the UNICEF office in Geneva. Next, we have Mohamed Saeed, Deputy Minister at the Ministry of Health of the Maldives. Welcome, Sophie. We have with us Shant, Shekherdimian, Advisor to the Minister of Health of the Republic of Armenia. Next, we have Elle-Mall Sadrak, Chairman of the Estonian Society of Family Doctors. And last but not least, my colleague and friend, Ewout van Gieneken, who is the Hub Coordinator at the European Observatory on Health Systems and Policies in Berlin. So now, following the setup by Triin, we will start with revenue generation, and I hand over to Lluis to ask the first question.
Thank you. Thank you, Anna. Let's just start with Klara. We talk about the revenue generation and the prioritization for health, no? And many countries struggle always to say, okay, how I prioritize, particularly when we are mostly living in hospital-centric models, no? Hospitals getting more attention and resources. So the question to you, Klara, is prioritizing spending on primary health is difficult. So can you share a bit the experience of Kyrgyzstan to bring more money into primary health care, and particularly during COVID-19? You can use my mic if you prefer.
No, okay. Thank you, Lluis. Of course, it's not easy, and Kyrgyzstan is not an exception. We are struggling for prioritize because we understand that PHC is the main path to achieve universal health coverage. And what was really helpful for us, that our health insurance fund, since the very early its foundation, we have our own budget, which is independent from the Republican fund. And that's why we can keep our eyes on the proportion of spendings, and that's why we can we can keep the PHC share on the same level. And not only keep, but we try to increase them. For example, if the payments for treated cases was increased in last year by 10%, capitation payment for PHC services was increased on 32%. And of course, COVID pandemic shows that health system needs more funds. And our government, they increased our total health budget twice. And it was our responsibility to increase investment for PHC. And we tried to do it. But we focused our efforts on the main critical position, it's medicine. Because annually our people out-of-pocket payments, they tend 10, 12 billion soms. It's maybe more than 30% of the total health budget. It's only for drugs. And that's why we increase for 45% the budget for reimbursable drugs on the outpatient level. Of course, it's not enough, but we try to do all what we can do in our situation. And I think that it's will never-ending battle between hospitals and PHC systems, but each financial system needs to create real financial mechanisms, real motivation stimulus for PHC, and we have to improve behind our Ministry of Health, behind our government, that PHC is the main, very important part of the health system. And that's why we are now working with the WHO, World Bank to improve our PHC payment system. UNICEF, he knows, because now we are developing the coefficients. We take into account the gender and age composition of the assigned population and the coefficients for destiny of population, because the main part of the Kyrgyzstan, it's very remote and mountains area, and we need to create very correct payment capitation rate. Now we are trying to do this. That's enough.
Thank you very much. An applause, please. Thank you very much, Klara. Just one thing that I want to highlight is you have brought the discussion out of the abstract world, primary healthcare hospitals. You say more money for medicines, which actually links to the point of Triin, no? Which is where catastrophic health expenditure, financial hardship happens. And then the playing with the provider payment mechanism, no, and the capitation that you are mentioning. So bringing into real world this challenge that we are facing of prioritization. Back to you, Klara.
Anna. Thank you so much, Lluis. We will now hear from colleagues from the UNICEF and the Maldives on something that I find really interesting. It's a primary healthcare costing analysis that they have been doing, and it's a tool that could potentially to higher allocations to primary healthcare or better allocation within the healthcare budget. So let me start with Manpreet from the UNICEF. Manpreet, you have worked on multiple primary healthcare costing analysis in a range of countries in the European region, in the Central Asia, and also in Africa and other countries. Based on all this rich experience during your work, what do you think are the key lessons from primary healthcare costing exercises for strengthening primary healthcare? Manpreet.
Thank you so much, Anna and Lluis, and thanks for the esteemed panel here. Honored to be speaking here on behalf of UNICEF. Let me start with the publication from WHO, which was in 2019, Guidepost on Investment in Primary Healthcare, which was a modeling study from 67 low and middle income countries, which talked about the per capita spending on primary healthcare is $15 to $60 per capita. That was a very important piece of publication from WHO, and congratulations for that. UNICEF started with support of Norway government, costing exercises in 40 countries around the world. I was lucky to participate on 6 of these exercises which are ongoing and have been completed. And I will share certain learnings from that, and I will stick to the time limit which has been given to me. First of all, the costing exercise in Pakistan, it provided information that around $26 billion are required for a period of 5 years. As per the current spending, which is by the government, the resource gap analysis stood at $5 billion per year. It's huge. It's huge. It's really huge for a country like Pakistan. Why this evidence-based information is important? This is important so that the government can prioritize their annual targets and they can work on that going forward. Secondly, if we look at where this money or how much of this money was required for which program, for the RMNCHA, which is reproductive, maternal, newborn, child health, and adolescent health, it was 64% of the total cost for this program, followed by 15% for infectious diseases and NCDs at 11%. As I said, resource mobilization is quite important when we talk about increased investment. And if you have heard, apart from PIC and UAC in the last 2 days, the top 5 words which have been spoken in the conference, they were investment, or it was financing, or it was costing, the synonyms. So it is quite important to invest in primary healthcare. If we look at the primary healthcare costing conducted in Kenya with support from UNICEF, again, it came out that the cost-benefit analysis is $16 for every dollar invested. So that's huge. Now, if we look at why it's not possible to increase allocations by countries, the reason is because Ministry of Health has to make a case to the Ministry of Finance and Planning. And one issue is of absorption capacity. Even if the funds are increased, whether the government will be able to put on these finances in the Ministry of Health pockets or not. So that is quite important. However, in some countries, they try to do a little bit extra for allocative efficiency. In India, there was a criteria introduced, which was on delivery points as a proxy criteria to identify facilities which have a higher case load. In case of Solomon Islands, where I worked in the Pacific, additional criteria was introduced. It was to introduce newborn facilities as an additional criteria for allocative efficiency. Now, if we also look at the work which has been done by other countries, let me highlight about Afghanistan. They have, in their costing study, a major cost which has come around 50 to 55% is on HR. If we ask the country to increase their HR to more than 1 per 1,000 doctors, nurses, and midwives population, 4.45 is what WHO recommends to reach by 2030. It's not possible because the HR is not available in the country. So every country has to prioritize their country-specific models for primary health care. Now, if I can just say in the final comment, when we talk about health financing, it's a very complicated theme. I totally understand. Many of us are economists, so we know that. But let me simplify it. There are certain things which do not cost anything. In Rajasthan, a district collector decided, why not beautify the primary healthcare facilities by free plants which are available from Ministry of or Director of Forestry, and let the facilities look more appealing to the people, while we say 48 hours stay is required after delivery. In other countries, like in Nepal, they said, why not put curtains, because we want safe abortion services and privacy is quite important and it doesn't cost a lot. Then there are certain costs which are not cost effective. For example, furniture. There are other costs which are highly cost effective. And I think nobody will argue with me here on the topic of breastfeeding. It is highly cost effective. Still, we see the initiation of breastfeeding within 1 hour of birth is high, but exclusive breastfeeding at 6 months of age is not high. Then there are other costs which are high cost, as I mentioned about infrastructure. And in countries which are facing war, again, there are higher costs because the primary healthcare facilities have to be built. So that's why their expenditure on primary healthcare is quite high. So with these words, I would like to share my thanks from behalf of UNICEF. It's great to meet with the experts here and to talk about the costing studies. And thank you so much, Klara, for the work which is undergoing in the country. And over to you, and thanks.
Manpreet, thank you so much for this very rich and insightful intervention. We often say that the ministries of health and ministries of finance don't speak the same language, but it turns out that it's possible to do so. Return on investment is a figure and it's a metric that the finance minister can clearly understand, or at least understand better than metrics that are more typically used in health, such as quality-adjusted life years, which is difficult to understand for most people. I think a return on investment of the magnitude of 16 to 1 is truly impressive and can make a really compelling argument for investing in primary healthcare interventions. So my comment, or rather a question, given time, we can keep it for the Q&A, is why we don't hear about more countries doing this sort of work? It would be good to hear maybe from you. Is this something that you do in your countries? And also, based on your experience, it would be really interesting to hear whether the work that you have done on primary healthcare costing has led to actual real results? Has it led to higher allocations for primary healthcare or better allocation for primary healthcare within the health budget? So thank you very much for this. But we have here with us Sophie, who is representing the Maldives, and they have recently conducted a primary healthcare costing exercise. So now, linking to my question for Manpreet, what has this led to? And interestingly, why have you done this in the first place? What motivated you? Sophie.
Thank you so much for giving us the opportunity to share our experience from the Maldives. So we conducted the costing exercise in the Maldives from 2021 to 2022 with the support from UNICEF. And the reasons why we conducted the primary healthcare investment case was because of our disease burden, which was exceedingly moving towards NCDs and mental health, which is quite concerning given the Maldivian population. And also because we felt that nationally we were moving away from the primary healthcare model. And one of the reasons why we were, and it was a bit concerning given that 11% of our GDP was actually dedicated to health. So why are we moving away from primary healthcare? And why are we dedicating so much of our budget to health infrastructure? Don't get me wrong, a lot of the health infrastructure is very beneficial to primary healthcare, but we felt that it needed to be, primary healthcare investments needed to be more robust and focused. So we wanted a baseline document actually for that we can build upon for healthcare management and professional staff, because we wanted to talk in a language that was understandable for our financial colleagues, that was actually understandable to them. We wanted to speak the same language as them. And preparing the budget, I would say, is one of our weakest points for healthcare management and professional staff. So we wanted a baseline document that can act as a reference when we're building their capacities in preparing budgets and, you know, focusing their investments in a language that our financial colleagues would be interested to invest in and work on and, you know, just help them. So according to our primary healthcare investment case, both costs and benefits of introducing priority PHC interventions for target populations, such as intervention packets for NCDs, mental health, Ramnaka, from 2023 to 2030, it estimated associated policy and program costs, such as media campaigns, health system costs, such as human resource costs for multidisciplinary PHC teams. So these are the sort of languages that our financial colleagues were actually interested in and were interested to invest in. And also, something that really caught their attention is that findings in terms of potential benefits of investing in primary healthcare was truly impressive. Like, for example, the analysis showed that such investments can result in 10,066 healthy years lived, which caught their attention. Something else that caught was over 200 lives can be saved using primary healthcare from 2023 to 2030. And also something else that they were really interested in is that early health impacts actually can be observed in 4 to 5 years from the initial investment. Because whenever we're talking to our financial colleagues, they're always talking about, okay, so where is the return on investment? When is the return on investment observed? And there's always a discrepancy between, there's always an argument between health and finance, because we're always talking about long-term planning, long-term investments. You can see the impacts in 10 years or so. But our financial colleagues always have a really hard time understanding, because they want to see it right now. They want to see the results of the money that they're spending, and we're not able to show it to them. But this document was actually showing it to them, and it's actually most visible with cancer prevention, which is very relevant to the Maldives, because one of the most prevalent diseases in the Maldives, according to our national disease burden, is cancer. And the analysis also showed that the financial impact of investments in NCDs and mental health leads to a cumulative gain of 15.42, which is equivalent to $1. So with every single rupiah that is spent on primary healthcare, on risk factor prevention, you gain $1. And on a final note, with respect to time, we are in the process of revamping our essential service packages for our healthcare facilities using this investment case focused on risk factor prevention and community empowerment, because prevention is always better than cure. Additionally, we'll be able to monitor the impact and the effectiveness of these service packages on an island level and appraise our human resource using a digital mechanism that we're developing with WHO using DHIS2. We've rolled out modules for NCDs and immunization, focusing on risk factors that, like tobacco use, dietary habits, who is avoiding medication, who is at risk of depression and anxiety, and the communities themselves, along with the healthcare professionals, are developing their own interventions, and we're able to monitor those interventions on a real-time basis. So this real-time data is leading to real-time decision-making and real-time course-correcting, which I would say leads to a brighter future. Thank you.
Thank you so much, Sophie. The numbers that you have quoted are truly impressive, and it's really also impressive, and I saw many people in the room nodding, that some of the benefits can already be visible within 4 to 5 years from the initial investments, which is actually short time, but politically it's quite long. So it's a very courageous decision to embrace this, given that political careers sometimes last much shorter than 4 years. And it's really interesting to see that you are using this exercise to inform the revamping of the benefits package. And you already have some results, which are the increased technical capacity within the health sector to prepare health budgets from now on. Let me pass over to Lluis, because we are a little bit over time.
Thank you. Thank you very much. Now let's move from, it's a pity that we have to rush you the time, because you are having very, very interesting stories to share. Let's move from beautiful islands in the Indian Ocean, and we go to a country that is trying large-scale health insurance reforms. Many countries that are having social health insurance reforms when it comes to primary health care, because many have been linked to hospital services. But then we say, okay, we have health insurance. How is going to work for primary health care? And, you know, and if medicines, as Triin was bringing us, it's where the problem is, how are we going to, medicines outpatient is going to be addressed from a health insurance model. And for that, we have Shant from Armenia. And we would like to hear from you, Shant, if you could share briefly, sorry for that, what is the plans in Armenia in terms of this large-scale insurance reform, and particularly how primary health care, you know, the primary health care benefit package is going to be designed, co-payments yes, co-payments no, why? Over to you.
Thank you. Thank you very much for the invitation to participate in this panel. The logic for financing of the healthcare system, and particularly the primary care system, flows from a couple of realities that are present in Armenia. The first one being that the recognition politically is starting to emerge that universal health coverage, which is the main goal for Armenia's healthcare system, will be impossible without the foundation of a strong primary care system. In addition, as access issues in Armenia are less of a contributing factor, there is a recognition that the care that is to be provided both within primary care and within the entire healthcare system must be of acceptable and high quality for there to be value good care in the country. So based on those premises, as well as the fact that Armenia grapples with a high out-of-pocket spending, the overall logic for health financing reform will be threefold. The first one will be to increase the overall government public expenditure within healthcare from the current percentage of GDP being quite low up to 4% by 2027. The second direction involving the financing reform for primary care will be reallocation of 40% of the budget to primary care spending, and I can sort of elaborate on where those expenditures will be going into. And the final one, again, because of the peculiarities in Armenia, and because of the issues that we have with the quality of care in Armenia, will be to focus on reducing unnecessary, inefficient expenditure or overutilization of healthcare, particularly within the primary care system. With regards to reallocation within the health budget into primary care, overall directions include very much changing the coverage of the essential medications. As Triin had mentioned earlier, the contribution of out-of-pocket expenditure into medications is the biggest contributor to the out-of-pocket spending in Armenia. And so one of the main goals will be to alleviate that. And then in addition, our second area of focus will be on introducing the blended methods of purchasing to focus more on results-based financing and decrease the contribution of capitations. So with that, I think that will be a good summary.
Thank you very much, Han. What is still shocking me is the available evidence that medicine is where the problem is, and that this defeats the normal or the usual expectation that is high, expensive tertiary care as the driver of financial hardship. This evidence has been around for 10 years at least, if not more. And still, when you analyze policies in countries, this is not where the policies are targeted. I'm still shocked, but it's great to see that at least Armenia, you are already putting the guns to the right direction. Now let's move from one relatively small country to another relatively small country in the Baltic. So, Elle-Mall, please. Estonia is a great example, quoted many times because of your dynamism on reorganizing primary health care and also on the blended payments. You were lucky to have some structural funds from the European Union, and I believe you use it properly. So can you share a bit this experience? Thank you.
Okay. Hello, everyone. I'm also honored to be here. I'm a simple person. I'm a family doctor. So I will give you my story. I started working as a family doctor in 2016. We had a team of 4 family doctors and 8 nurses. 1 family doctor and 2 nurses, the typical contract you have in Estonia for family medicine. Our building was old. It was not meant for offering healthcare services. Some kind of library rooms were given to the family doctors. No money was invested after Estonia regained its independence in the 90s from the Soviet Union to the infrastructure. So you were kind of stuck in the old rooms you had available because the money you got from the insurance fund didn't cover the nicer and bigger rooms. So in 2017, Estonia was eligible to apply for EU funds to renovate or to build new infrastructure for primary care healthcare centers, which are multidisciplinary. So the criteria to have a healthcare center and to have the fundings from the EU were you had to have minimum of 3 family doctors. We had 4. You had to have minimum of 6 family nurses. We had 8 at that time. You had to have a midwife. We didn't have. You had to have a physiotherapist. We hadn't. Then you had to have a home nurse registrator. This was the minimum package. We found the people. We got the fundings, and in 2018, we opened our healthcare center. By the time where we are today, our team also consists of 3 mental health nurses, 2 additional physiotherapists, clinical psychologists. So our team has grown a lot. It wouldn't have been possible only with the fundings from the EU. If our insurance fund wouldn't have come up with a separate contract for the multidisciplinary teams, the infrastructure, it wouldn't been enough. Today in Estonia, we are facing a problem of family doctors being old. The average age of Estonian family doctors is 60 years. I'm a rare example. And this means in the next following 7 to 6 years, around 1/3 of our family doctors, they will retire. 1/3, that's a lot. And this means we need to think how we can add additional team members to our teams, multidisciplinary teams, and we are working together with the insurance fund and the government to have those additional people. So money only isn't going to help. You need to have a vision in place where you want to go. But if you don't have the infrastructure, it's also quite difficult to have new additional services for your patients. Yeah, thank you.
Thank you very much. Well, I'm sorry to say, but if every simple person like you would have this policy clarity, we would be in a better world, definitely. Thank you very much. Just a couple comments, no? The importance of teams, no? You know, still many countries struggle to get that right, no? And to put them together. And the other is the complementarity of, okay, the European Union money help on the infrastructure, but you said very clearly, without the recurrent costs and the contracting that comes with it from the insurance, this would not fly. And then there's an idea to float this, what is the entry point of the PHC reforms? In every country are different. So perhaps, and sorry, I don't know another Estonian case, in your case, the investment, it was the entry point, but definitely it triggered all the rest, no? So one reflection for all of us is when we are trying to stimulate the primary health care reform, where the opportunity comes from. In this case was this grant or a loan, and then you did the rest. Anna, over to you.
Time is running very quickly, and we are drawing to a close of the session. So we wanted to finish on a futuristic note, and my colleague Ewout, who is the co-author of the financing chapter in the very much anticipated PHC primer. We would like to ask him to share his thoughts on what he thinks are the future challenges in primary healthcare financing, and to make his task even more difficult, what do you think are the ways to overcome these challenges? Ewout.
Well, thank you, Anna, also for inviting me, and also thanks to the co-author, Triin, for co-authoring this chapter together, which was great fun, and you should definitely read it, download it, get a copy. It's such a difficult question, on the flight here, which was last night. I've been thinking a lot about, what can I say about financing? It's such a broad issue. I can talk about revenues, I can talk about pooling, allocation, purchasing, payment systems, benefit package setting. But you wanted me to talk a little bit about the future and perhaps maybe focus on something that I maybe haven't heard so much here yet. But although I think the contribution from Estonia was really already dealing what I see as one of the major challenges, which is the rising numbers of people with multimorbidity. And I think that the way to address that is, of course, to move from a model that is often based on single diseases and often also paid that way to a model that is more integrated, has a more holistic view of the patient. And for that, you need, of course, a much broader group of providers around you, so a multidisciplinary team, the way you're doing in Estonia, and what I see in many other countries as well. So to create these models, and it was really interesting what you said about that is that the Estonian Health Insurance Fund was on board in funding some of these pilots and then starting the initiative, because this is really key. In some European projects that we have done, we saw perfectly fine pilots with good results stopping because there was no future, there was no avenue towards the regular financing system. So if you start with these kinds of projects and funding them, there needs to be already a thought, how can they later be integrated? And also they should have a long-term view, because sometimes these results will not arise immediately. So I think that those are some important points. So then, if you would look at this holistic model, what does it mean then? It of course also means really looking at a patient in his or her environment and also looking at their financial means. Do they have transport? Are there carers available? And I think the question also in terms of funding primary care is also in how far does primary care play a role here? And then I'm also thinking of, for example, social prescribing, which is something we see more and more in Europe. Where a doctor gives a referral to a link worker who then helps a patient finding all kinds of support services in social care in their location. And this, of course, can differ greatly, but I think plays an important role. And I think there's also some thought to be put in there, whose responsibility, which budget, should it be pulled together with social care? So that's another issue I see very clearly that I think, in the future we have to address. Well, you also asked me, so what could be some of the solutions? And, the things that we have seen in several settings is, for example, how can you pay for integrated care, or let me say coordinated care? I had a discussion during lunch with about this issue, and I think that integration often gives the wrong impression. It's often just also coordination, not some structural integration. And it can be, depending on the level of maturity of your health system, something quite simple, just additional payments for slightly better coordinated care. And you can think of paying a pharmacist to do a pharmaceutical review, and that there are no contraindications there. That would be a relatively easy thing to do. Harder are, for example, bundled payments, where groups of providers come together to take care of chronic patients. That already demands a bit more from the health system, also in terms of raising the data, something that Triin also talked about, very important. And they have the issue that bundled payments often do not really fit with people with multimorbidity, whose costs are really hard to predict. So there's also, I think, some work to be done to figure that out. And then there are also shared saving models that we are seeing slowly developing. We know them from the United States. There are few examples also in Europe. For example, the Gesundes Kinderspital model in Germany. Basically, where a group of providers come together, and if they can provide care for a certain group for less than they would get from the usual financing system or another benchmark, then those profits would be split between the payer and the provider. So that is another example that I see. Although I have to say that this requires a lot more in terms of data, because you really need to measure quality. Especially if these payments get so much broader, you need to know what is happening on the floor, and to properly make sure that there is no, for example, skimping of services. And also it will require more potentially from providers in terms of the kind of reserves they need to have to be able to take on the risk. Although there are also some solutions for that possible, where perhaps the payer or the government can assume some of the risk. So. I think I see you jumping around a little bit nervously, so I'll leave it at that. I had some other points, but maybe in the Q&A.
Thank you so much, Ewout. So health financing in itself, it's a very complex topic, and the primary healthcare financing is even more complicated given the challenges faced by primary healthcare, such as multidisciplinarity, multisectoriality, and often the new models of financing are only emerging. And we're just learning. There are some examples in the book, but they are quite new, quite dispersed, not so many of them. So, and many countries will not have the technical capacity to develop such models. So as we heard, the Maldives are learning, building up their technical capacity to improve their budget planning. But these things that you described are really complex. So one thing that we can do to help is to learn from each other, such as by gaining these insights as we do today, by using colleagues at the Barcelona office who have high technical expertise, by using the wider WHO and colleagues at the UNICEF with the costing work to learn, because we don't have to do it all alone, right? So we have, I think, 2 minutes for maybe 2 questions 3 minutes for 2 questions from the floor. If you have a pressing one that you would like to ask.
This is a bonus that they offer to us by being disciplined with their time. So please, we have 1, 2, not allow more.
Yes, my name is Hassan Mohamed. I'm from the Maldives. So I'm not definitely going to ask my Maldives colleague this question. And in fact, I'm not going to ask any one particular panelist. But I've always wondered, when we talk about the government spending, per capita spending on health, we celebrate, okay, this country has spent so much. This country is spending so much. That versus do you have a threshold? Like, maybe you are spending, if your disease burden is high, then you're spending more. So is that a good thing? What's the threshold in correlation with the health indicators at one point? If a country has these health indicators, then per capita GDP expenditure on health can be at this level. So more spending, is that a good indication? Or is that a sign of more disease?
Let me abuse of my power of mic and answer straight, no. And now let me share a bit the experience. For example, we are helping Malaysia. They have done a health white paper. Malaysia is a very good performing model, but they are a very low spender. And they are obsessed that they have to spend more. And our question back to them is, spending is not your goal. You have problems, maybe your hospitals are overcrowded, you might perhaps need to do a better job of NCDs, but the spending is not your goal. It's a means to an end. And they are doing a fantastic job. They have less catastrophic health expenditure, financial hardship, than Japan and Korea, which are spending much more than them. So there is no magic number for that. Last.
It's kind of continuation still, despite the very short and concise answer. My name is Akak Zoidze, I'm from Georgia. And it's not about the magic figure, but usually it's about policy advocacy. When you really advocate for more spending on primary health care, because definitely you are not spending enough in such cases. And one is financial protection indicators, and you can make this argument with ministries of finance or the key agents to advocate with. But then another dimension is the health dimension. And health dimension, 45 years, I think you are have very progressive Ministry of Finance people that are satisfied with that, because in our countries, mostly it's 4 years, and they would prefer open dialysis centers with ribbons and happy dialysis patients rather than spend for outcomes that will be after 45 years. So any short-term or medium-term effects during those studies that you do in Western cases, because that's very important. And the second, spending on what? Because in most countries, OECD considers primary health care without pharmaceuticals. WHO global measure considers with pharmaceuticals. And it's a huge difference. And some countries consider specialist care as part of the PHC and the guidelines. Some countries don't. So that's another argument with Ministry of Finance when you're asking, for more money. You see, these guys are spending more and they have even less money than we have in the economy. But then the question is what they're spending for in there. And it's a major problem with that. And maybe we could think about some key tracers, interventions like NCD packages that could be costed. And then in this case, you can also say, this is what they're spending on these specific services. And you might consider this as a peer comparison and fair comparison. So any thoughts about that will be appreciated. Thank you. Over.
Thank you very much. Actually, your nuances are, I would say, quite reasonable, and I don't disagree personally. But I want to give, we have 1 minute overshooting, but?
I will complete in 30 seconds. First of all, in the short and long term, the costing studies, as the question also asked by Anna, they are very good for advocacy, and especially if you use the language of impact assessment, how many lives are saved, rather than QALYs and DELYs. So they're very good for advocacy, especially when Ministry of Health has to make to the case to the Ministry of Finance and Planning, as you heard from Maldives also. It's a very good advocacy document. Although there are shortcomings, there is methodology, it's again estimates, but it is the best possible guesstimates. But in the short term, advocacy; in the long term, better health outcomes. Over.
Okay, just to end, I think all magic numbers or benchmarking, I think that they will be useful as long as they open policy space and discussion. So it's a starting point, perhaps some benchmarking. In the case of Maldives, you can have a magic number to start sitting and discussing. And then comes all the nuances that the colleague from Georgia has shared. No challenge here. So I think we have overshoot only for 3 minutes, which is quite an achievement for this conference. So thank you very much for your attention, and thank you very much to all speakers. Fantastic job.